Legalizing suicide strikes at the heart of what we do as physicians, and it leads to ambiguity in the doctor-patient relationship. Under the pretense of providing compassion, the physician is relieved of his or her primary responsibility to the patient, to provide comfort to the suffering. It is the ultimate patient abandonment. Furthermore, as oncologists, while we are aware of the limitations of providing palliative care, we recognize that even many other physicians in other specialties who do not treat dying patients with any regularity, they may not see what we see. We believe that far fewer physicians would support the concept of physician-assisted suicide if they had specific training and experience, as oncologists do, in dealing with these types of patients and these diagnoses. This bill, AB 654, mandates that a second physician provide a consultation. But the concern that I have is that the second physician may very well make the same error in judgment as the first physician, not because of a lack of information, but because information changes over time. As a hospice medical director, I must certify that a patient is terminally ill with a prognosis of 6 months or less. But when I'm wrong, if the patient is still apparently terminal but has not expired in 6 months, that person can be recertified for another 6 months, or perhaps if their condition improves, they can be graduated from hospice. If my prognosis were wrong in regards to a patient choosing a lethal injection, the patient pays the ultimate penalty.
A few words about Oregon, which will help explain why the organizations I'm representing are so opposed to this bill. This bill is deeply flawed, just like the Oregon law that keeps us ignorant of what's really going on. Doctors who fail to report their lethal prescriptions in Oregon face no penalty. The law gave no resources nor even authority to detect violations. All we know from the state's research that is always complimented at how glowing it looks, all we know comes from doctors who prescribe the drugs. The state doesn't even talk to doctors who refuse to assist the very same patients to die. Doctors who might reasonably have opinions that the people who wanted the lethal drugs didn't meet the guidelines. Only the doctors that gave the drugs are talked to. Autopsies are not required, so there's no way to know the deceased was actually terminally ill, opening the door to another Dr. Kevorkian. Several cases inconsistent with the law, which Dr. Stevens has given some of the content of, were never reported by the Oregon research, only by the press. Last month, an editorial in the Oregonian complained that the law's reporting system seems rigged to avoid finding the answers. Campaigners argued the Oregon law would bring the practice out in the open, but assisted suicide is practiced in secret and without oversight in Oregon. This bill contains these fatal flaws, and California should reject it.
Dr. McGregor, welcome.
Thank you very much. I'm a hospice and palliative medicine physician. I've been doing palliative medicine initially in Canada since 1981 as part of my practice. It's now the sole aspect of my practice that I do. I have been at the bedside of hundreds or thousands of patients who have died. I have had patients request of me that I give them the magic pill to help them end their lives. And the answer is not to give them the magic pill. The answer is to inquire why they want the pill. What is it that they are wanting? What is it that's behind the request? Is it a fear? People now, if you think about your death now, you may be reminded of someone who has died and their death was not properly managed. There was pain, there was suffering, and you may think, I don't want that. So if the choice were given to me, I'd want the pill. I'd want to be able to end my life at that moment. Of the patients who've requested that I give them the pill, which of course I did not do, and of the conversations we've had that we've had to include the family, their loved ones, their significant people in their lives, they have, sometimes beyond the 2-week limitation, said to me, I'm glad that I didn't do that. I found out what's important in life. I found out how to give and receive love, how to be loved. And even in my debilitated state, lying here in bed, I've been cared for tenderly and lovingly by people. and I've learned a lot about the human spirit. We're talking about a bill for a small number of people who might request this. And really, as a society, we have a responsibility to care for the most frail and vulnerable in our society, and those are people facing a life-limiting illness with a poor prognosis and a shortened lifespan. How do we deal with them? Someone mentioned having conversations about whether you want suicide. I say we have conversations about how do we care for these people who have no place? How do we care for these people who have no insurance who are dying? And how do we find out what it is that they want? What is their preference and their goals? The conversation about what you want at end of life doesn't start when you have 6 months or less. It needs to start when you're much younger, to look at what it is that's important to you. A colleague of mine cared for a Canadian Olympic athlete, track and field star. He was training for the track and field. He was diagnosed with cancer. He apparently was cured of his cancer. He started training again. His back started to hurt. Typical athlete, he decided, well, that's because I'm training again and I haven't been training. His legs started to get weak. He ended up with metastatic disease from his original cancer. He spent the last 12 months of life in bed. He confided to my colleague 2 weeks before he died, "This has been the best year of my life." He was afforded an opportunity, he said, to learn what it was like to give and receive love. What about autonomy? Autonomy is one of 4 medical ethical principles. The other medical ethical principles are beneficence, maleficence, and justice. The question then comes, what is it as a society that we can do for justice? Is it the justice for the individual, or is it the justice for the whole of people, the justice for those who are facing a life-limiting illness, who are the most vulnerable in our society? And we need to look at what we can do to provide justice. And sometimes justice trumps autonomy when we're looking at how we're going to care for these frail and vulnerable people. We have a responsibility and an obligation as a society to act in a loving, caring manner, help people through a very difficult transition, to treat them with respect and dignity and love. I've seen patients and families grow when they've done the transition, being supported by caring, well-educated professionals. What we're missing to a great deal of extent is the opportunity for those people to even know that hospice is available to them, and to educate them, educate other healthcare professionals what it is that provides good care at end of life, and what that transition can look at. We spend thousands or millions of dollars on the transition that brings us into this world. We have an equal responsibility for the transition out of this world. Thank you very much.